Hello everybody, welcome to today's webinar by the Global Antibiotic Research and Development Partnership, GARDP. My name is Victor Kwasi and I'll be hosting today's session on new technologies and strategies to overcome the challenges of sexually transmitted infections. The presentations in today's webinar were also given at a satellite session at the 2021 International Conference on AIDS and STIs in Africa, ICASA. Revive is GARDP's education and outreach program. It aims to connect and support the antimicrobial R&D community by facilitating learning, sharing knowledge, and connecting people. These webinars are part of our educational activities. All the webinars are recorded and now freely available to view after the live broadcast on the website revive.gardp.org/webinars. And as well as the webinar recordings, you can also read our series of articles known as Antimicrobial Viewpoints. And you can also find definitions of the terms that will be used today in our resources section, which also includes the Antimicrobial Encyclopedia. So as always, today's presentations will be followed by a Q&A session. You can submit your questions at any time during the webinar through the webinar control panel as shown on the slide. We'll address the questions after the presentations and do our best to respond to as many as possible. Today's moderators will be Amir, Shroufi, and Remco Peters. Just before I hand over to them, we will first have an introduction from Teodora Wi from the World Health Organization. Welcome, Teodora, and I'll hand over to you.
Thank you so much, Victor, and thank you for GARDP for organizing this session. And welcome to the session on the new technologies and strategies to overcome the challenges of sexually transmitted infection. In 2020, WHO estimated that there are about 374 million new cases of STIs, and this is for Treponema pallidum, Niceria, Gonorrhea, Chlamydia, Trachomatis, and also Trichomonas. More than 500 million people have genital herpes infection, and about 604 cases of cervical cancer were diagnosed among women worldwide in 2020, which is very much linked to the human papilloma virus. When left untreated, sexually transmitted infection can lead to long-term, irreversible, and potentially fatal sexual and reproductive health outcomes, including pelvic pain, cancers, ectopic pregnancy, infertility, and adverse pregnancy outcome, neonatal deaths. And in addition, this increases the risk of HIV transmission and acquisition. Yet, there has been a major lack of progress in addressing this infection, and a large proportion of infection remains undiagnosed and untreated. These infections continue to also result into stigma and are often hidden. Sexually transmitted infection remains high, and there's a significant burden that we have seen. The global response has lagged severely, resulting into the lack of visibility, funding, and implementation support. There is a need to re-energize the response, and as a result, in 2020, by 2022, we now have a new global health sector strategy, which will require a very much needed key strategic and operational shifts, requiring, for example, the need to create an environment that enables individuals to comfortably talk about their sexual health, adopt safer sexual practices, and seek treatment for sexually transmitted infection. There is also a need to vastly scale up primary prevention and increase access to screening of sexually transmitted infection. There's a need to increase access to high quality, people-centered STI case management delivered by both the public, the private, and the non-government service providers. And of course, there's a need to integrate sexually transmitted infection services to primary health care, to adolescent health, to sexual reproductive health, to HIV, to family planning services. And of course, very importantly, is to ensure sufficient financing for sexually transmitted infection services as part of the national health financing system mechanism. And as we will be talking more further today, is to really look at how we should be strengthening the national health information system to ensure a timely collection and analysis of data to inform policy, advocacy, treatment guidelines, and programming. And lastly, what is so important is really to support the acceleration of research and development and innovation for prevention technologies, for new diagnostic and treatment strategies, for new treatment that would be needed, and vaccines for sexually transmitted infection. So now this is going to be a very interesting topic that would really look into all this strategic shift. And now I move forward to Amir to give us an introduction of the session. Thank you so much.
Thank you very much, Teo, for that excellent high-level framing. My name is Amir Shroufi. I'm a doctor and a medical affairs advisor with GARDP. So this session, following on from what Teo said, is all about addressing sexually transmitted infections through innovation. We're talking about very old infections, but infections for which the challenges of dealing with them are not going away. In fact, they are really getting more challenging to deal with because of the emerging specter of antimicrobial resistance and other issues. But there are new therapeutics and new diagnostics that can help with help address these issues, and that's what we're going to hear about today. These things have the potential to transform both the clinical and the public health approach to sexually transmitted infections. We have some great speakers to take us through those challenges and solutions. And the first speaker, who I'm just going to introduce very briefly, is Ranmini Kularatne, who leads the STI section of the Center for HIV and STIs at the National Institute for Communicable Disease in Johannesburg, South Africa. Ranmini is a clinical microbiologist, advisor to the STI Guideline Development Group at the WHO, and an executive committee member of the International Union Against STIs, as well as lecturing at the WITS Faculty of Health Sciences. Ranmini, over to you.
Right. Thank you very much for that introduction and for inviting me to present on STI surveillance findings from South Africa. And I'm going to focus on antimicrobial resistance and key populations. Next slide, please. Okay, so I'll briefly discuss the local epidemiology, some of our routine sentinel etiological surveillance findings, including AMR in key pathogens, key causative pathogens of these STI syndromes, how we conduct surveillance for AMR and emerging STI pathogens in key populations, and how we use this information or could use this information for policy and action. Next slide, please. Right, so we have modeled some of our prevalence data from surveillance studies conducted in adults attending family planning clinics, antenatal clinics, and also from household surveys in order to determine the burden of these infections in the South African adult general population, aged 15 to 49 years. And if you have a look, for 2017, we had almost 4.5 million cases of gonorrhea and 6 million incident cases of chlamydia. And we modeled these data from our prevalence findings using the Spectrum STI modeling tool. Next slide, please. So we have a high burden of STIs in South Africa, and it's essential that we conduct etiological surveillance of the main STI syndromes. And this is one of our core activities at the National Institute for Communicable Diseases where I work. Next slide. Right. So if we have a look at the most common STI syndrome in men, this is male urethritis syndrome, and these are sentinel surveillance findings for 2019-2020. We conducted surveillance in 3 high-volume primary healthcare facilities in 3 provinces of the country. We enrolled almost 770 men. If you have a look at this, you can see that the main causative pathogen is Neisseria gonorrhoeae, followed by Chlamydia trachomatis. So our treatment must cover these 2 pathogens. Next slide, please. And another key activity is the monitoring of Neisseria gonorrhoeae antimicrobial susceptibility profiles. And we look at the minimum inhibitory concentrations. And if we look at 2019, 2020 data, we had about 540 isolates from these 3 sites. And you can see that we don't really have resistance to ceftriaxone. We have not identified resistance to ceftriaxone. The resistance breakpoint is an MIC of 0.25. And we also did not identify resistance to azithromycin, but we are monitoring this very carefully because we are seeing sporadic cases of azithromycin resistance in Neisseria gonorrhoeae. And I'll speak to this a little bit later. Next slide. And it's very important that we monitor antimicrobial susceptibility profiles because, as you know, Neisseria gonorrhoeae has the capacity to rapidly evolve and develop resistance to first-line antimicrobial agents used to treat gonorrhea. If we look at surveillance findings from South Africa for ciprofloxacin resistance, now we stopped using ciprofloxacin to treat gonorrhea in 2008, and we changed to Cafixine. We did this a little bit late. It was a delayed transition because the resistance prevalence in 2008, the ciprofloxacin resistance prevalence, was already about 25 to 30%. And you can see that even though we stopped using ciprofloxacin, in subsequent years, there has been an exponential increase in ciprofloxacin resistance, which tells you 2 things, that this resistance does not confer a fitness cost to Neisseria gonorrhoeae, and also there is selection pressure due to continued use of ciprofloxacin at primary healthcare facilities for other indications, such as urinary tract infection treatment. Next slide, please. Right, and this is why we monitor etiological profiles of these main syndromes, so male urethritis, vaginal discharge, and genital ulcer. And it's because we treat STIs syndromically in South Africa. So we manage those patients presenting, and most of these patients present to primary healthcare facilities with signs and symptoms. And we acknowledge the limitations of syndromic management, but it is a pragmatic approach. Because in order to identify the etiologies of at-risk of STIs in at-risk persons who are asymptomatic, we would require a cost-effective, rapid, accurate point-of-care test, which is readily available at these primary healthcare facilities. Because as I said, most of these patients do present to PHCs. Next slide, please. We also submit antimicrobial susceptibility data to the WHO, to WHO GASP and GLAS. And these represent national data from South Africa. Next slide, please. Okay, so in 2008, we changed from using ciprofloxacin to Cafixine for gonorrhea treatment. And then we noted the emergence of Cafixine resistance in 2012 when 2 men presented to their private healthcare practitioners in Johannesburg with persistent urethritis despite Cafixine treatment. And this was not picked up through routine surveillance. These private GPs submitted specimens of urethral discharge to a private laboratory, and they detected Cafixine-resistant Neisseria gonorrhoeae, which was confirmed by the NICD. And these isolates belong to multilocus sequence type 1901. And this was a multi-drug resistant clone of Neisseria gonorrhoeae characterized by resistance to extended spectrum cephalosporins. These 2 men were MSM with links to international sexual networks in North America and Europe. And so travel history also becomes very important. Next slide, please. So recognizing the fact that there was Cafixine resistance emerging in South Africa amongst the Niceria gonorrhoeae, and also recognizing the fact that we had limited surveillance data from key populations such as MSM, there was a national change in recommended first-line therapy for gonorrhea from oral Cafixine to injectable ceftriaxone plus azithromycin. So we started using dual therapy, and this was also in accordance with the WHO recommendations at the time. More recently, several countries have started using single agent therapy, so high-dose ceftriaxone to treat gonorrhea, and they have omitted azithromycin therapy. And this is because they have detected outbreaks, clonal outbreaks of Neisseria gonorrhoeae with high-level resistance to azithromycin. They've seen the emergence of azithromycin resistance in Neisseria gonorrhoeae, as well as other STI pathogens, such as Mycoplasma genitalium, and also organisms in the respiratory microbiome and gut microbiome. And this is because azithromycin has a long half-life and a long therapeutic tail. So you do have sub-inhibitory concentrations persisting for up to 4 weeks, even after single-dose therapy. This is something we are monitoring very carefully amongst our Neisseria gonorrhoeae isolates, as well as Mycoplasma genitalium. And our treatment guidelines will be based on local surveillance data as well as WHO recommendations. And we may well adopt single agent therapy in future. Next slide, please. Okay, so ceftriaxone resistant gonorrhea is a notifiable medical condition in South Africa. We have developed a protocol for standardization of Neisseria gonorrhoeae AMR testing across National Health Service laboratories. And we've also developed a case investigation form. So if such a case is detected, we will collect information on travel history, on recent sexual partners, so that we can quickly trace and test and try to curb the emergence of ceftriaxone resistant gonorrhea, emergence and spread. Next slide, please. Okay, so there is a paucity of data from key populations in South Africa. Now, this was a study done amongst MSM at a men's sexual health clinic in Cape Town in 2012. And you can see that the commonest pathogens are Neisseria gonorrhoeae and Chlamydia trachomatis. Most infections were extragenital at the rectal or oropharyngeal sites, and most infections were asymptomatic. So would go undetected and untreated unless these men were screened and tested using a diagnostic assay. Next slide, please. Okay, so late last year, the NICD commenced a pilot STI surveillance study at an MSM clinic in central Johannesburg. And this was to determine the feasibility of establishing an early warning surveillance system in a priority population in South Africa in order to monitor for emerging resistance to ceftriaxone in Neisseria gonorrhoeae, and also to monitor for emerging STIs in key populations, such as rectal LGV. And we know that there's an epidemic in Europe and North America of rectal LGV amongst MSM, and we didn't have much data from South Africa at all. Next slide, please. So just to mention that we are going to expand that surveillance this year amongst MSM, and we will be able to culture Neisseria gonorrhoeae and monitor for resistance. As I mentioned earlier, we also monitor azithromycin resistance in Mycoplasma genitalium, another key pathogen. Prevalence is quite low at the moment, but we will continue to monitor this. And we also are a reference laboratory for testing specimens from patients with persistent STI syndromes. And it's very important to establish the etiologies and the antimicrobial resistance profiles of organisms from these patients. to see if there's emerging resistance. Next slide, please. So we do sporadically detect cases of multi-drug resistant Mycoplasma genitalium, and these are mostly amongst patients with links to international sexual networks. We also investigate the etiologies of persistent STI syndromes. We've developed guidelines for this, and we ask clinicians to submit specimens as the reference laboratory for this. Next slide, please. So what is our future surveillance strategy at the NICD? We will continue surveillance for resistance to first-line agents in Neisseria gonorrhea. As I said, we are going to extend to priority population groups such as MSM. And we will also test specimens from extragenital sites such as the pharynx, because this is where resistance commonly evolves. This is ceftriaxone resistance in Neisseria gonorrhea due to sub-inhibitory levels of the drug in the pharynx, and also because there's an opportunity for genetic transformation of Neisseria gonorrhea. We will continue to do etiological and antimicrobial resistance testing of treatment failure cases with persistent STI symptoms. We will closely monitor resistance to azithromycin in Neisseria gonorrhea and other STI pathogens. And we will also contribute whole genome sequencing data to better understand our resistance determinants, relatedness to global Neisseria gonorrhea strains, to understand our transmission dynamics, and to provide African data for vaccine development initiatives. Thank you very much.
Thank you very much, Ranmini, for that excellent overview of the surveillance landscape. Our next speaker is Saika Molek, Director of Implementation Sciences at Wits RHI and Associate Professor in the Faculty of Health Sciences at the Wits University in South Africa. Saika is a medical doctor with a PhD in infectious disease epidemiology, overseeing a large portfolio of research in HIV prevention, sexual and reproductive health. Saika is a principal investigator for a number of ongoing trials and has served on the WHO STI Guideline Development Group, as well as being co-chair of the WHO Technical Working Group for the Consolidated HIV Strategic Information Guidelines. And Saika, over to you.
Thanks very much, Amir, and thank you very much for this opportunity to really provide a high-level overview of some of the implementation challenges, health systems issues, and monitoring gaps with regard to STI prevention and management in South Africa. And I hope that this talk can provide a framework as we discuss potential solutions and areas for strength and focus later on in the session. Next slide, please. So South African prevalence rates for STIs are amongst the highest in the world, with rates of curable STIs highest in younger people, in particular younger women. And studies have also reported high rates of both incident and prevalent infections amongst PrEP users, with almost a quarter of young women having a treatable STI. High rates of asymptomatic infections are common, particularly amongst women. And also prevalence of congenital syphilis has been showing an upward trend in recent years, with prevalence of maternal syphilis over 2.5% in 2019. There's also this high disease burden, particularly amongst young people, which coexists with significant health systems and social barriers to both information and health services for STIs. Next slide, please. So in South Africa, implementation guidance exists for the detection and management of STIs, and it's available in a number of policy and guideline documents, including guidelines for STI management, for pre-exposure prophylaxis for HIV, maternity care, as well as sexual assault. And implementations monitored through routine M&E indicators collected at public sector sites as well as some sentinel surveillance sites. There's also a quality assessment tool, which is called the DISCA tool, or District STI Quality Assessment Tool, that's to be used to monitor quality of healthcare at healthcare sites. Next slide. So the recommendations in national guidelines, it aimed to sort of ensure a balance between primary prevention, secondary and tertiary. And primary prevention approaches include the provision of trusted information through a national youth-friendly platform, male and female condoms, and vaccination for HPV and hepatitis. Secondary prevention interventions include a recommendation for routine syndromic screening, particularly for youth, as well as targeted screening through testing in populations such as pregnant women, those experiencing sexual assault, and Hep B screening for PrEP and ART clients. And partner notifications also recommended as part of management. Our tertiary prevention includes syndrome treatment, which might miss many asymptomatic infections and also overtreat some syndromes such as vaginal discharge syndrome. Etiological approaches and drug resistance monitoring are limited to selected sites and research projects, and neonatal diagnosis and treatment are also covered in the implementation guidance. Next slide, please. So this slide shows a value chain framework that aims to identify key components that need to be in place for comprehensive STI services to be implemented. And these components include planning, budgeting, and supply chain, ensuring policy and guideline frameworks, as well as resources, are available for all components. Guidelines and provider training in commodities, including tests, drugs for treatment, and also ensuring that the most cost-effective and integrated service delivery models are implemented at multiple entry points in the health system. There's also end-user support which is needed, which currently includes online national platforms and counselling as part of service provision. Monitoring and evaluation, which includes routine monitoring and annual sentinel surveillance of STI syndromes, is also included at sentinel sites. Next slide, please. So, although there are many components in place, as my previous slides show, there are also significant challenges across the value chain, which I'll discuss over the next few slides. Resources for strengthening the program are scarce, and there are limited resources to implement an etiological approach for all key and priority populations, despite provision in the guidelines. I think Ranmini mentioned the need for cheap, rapid diagnostic tests to enable this. A DISCA assessment conducted in 6 clinics in 3 provinces in 2019 revealed some gaps in terms of drug availability for STI treatment, the lack of female condoms and lubricant, as well as rapid syphilis test kits, specular lights for client examination. Healthcare providers also reported needing training on STI screening and treatment and mentioned a lack of job aids, with some facilities still having old guidelines on site. Medication stockouts, equipment and space shortages, as well as long clinic waiting times and healthcare provider attitudes were also cited as barriers to STI provision and integration. Next slide, please. So this slide shows the current widely implemented service delivery model, which highlights some limitations, including limited access to information, as well as challenges with linking people to services, which might not be youth-friendly. Although routine syndrome screening is outlined in the guidelines, it's not consistently implemented, with some facilities having a siloed approach and no routine indicators to measure integration. The widespread implementation of the syndromic approach misses many infections, particularly in women, but also in men, and may also result in overtreatment of vaginal discharge syndromes, as I mentioned previously. Etiological approaches are not widely implemented, and the use of partner notification slips and healthcare provider notification are poorly implemented and not preferred by young people, but also not well documented. So the service delivery models have been the same for a long time and have not been guided by recent empiric data on youth service delivery preferences. And we'll share such data later in this session. Next slide, please. So treatment uptake and partner notification and treatment also needs strengthening. And a study amongst men revealed that less than 2/3 of those identified with an STI received treatment, and low treatment uptake was even found amongst young female PrEP users, even when their STIs were confirmed through a diagnostic test. Studies have also shown poor compliance with treatment for syphilis amongst pregnant women. Healthcare providers report challenges with partners returning for treatment, and this has the potential to undermine our best efforts at reducing transmission. As one provider stated, what's the use of treating one partner if the other partner is also infected? If you treat this one and then they go back to the same partner who infected them and come back again, and we get that. People who come to the clinic frequently for the same condition, it's very frustrating. Next slide, please. In terms of client support, our social media platforms show a high reach and high levels of engagement. They also show a need for information with many questions about STI symptoms and availability of services. The existing platforms are reaching youth, but there's a need for more engagement around STIs, more information and clear pathways to linkage have the potential to improve uptake of prevention services. Integration with other services such as PrEP services, this slide shows that AGYW coming in for PrEP services are at risk of STIs, and we can see high rates of treatable STI among these clients. And so we need support to clients across the cascade of care. Next slide, please. So this slide highlights where program M&E data is collected across the cascade of care for STIs, starting with those that are reached with information, linked to care, screened and tested, treated, completed treatment, their partner notified and treated. And at most clinics, except sentinel sites and research sites, where more data is collected, there's a limited set of indicators, primarily male urethral syndrome, which are collected. And where you can see the red blocks, where it shows where we have limited programmatic data. Next slide, please. So in conclusion, although many elements of the program are in place, there are areas across the program where significant challenges are faced, and we require innovative solutions. We need to improve the basics, including health system infrastructure, supply chain, availability of routine commodities. We need ongoing capacitation and quality improvement interventions that must be implemented to ensure that the guidelines are implemented and gaps addressed. Routine monitoring systems need to be strengthened to ensure that gaps identified across the cascade can be detected, and that program adaptations are informed by quality data. We need to focus on ensuring primary prevention is strengthened, including the use of existing available interventions, and we need to implement and evaluate novel interventions that are client-centered and that include partner management. We will, in the following presentations, discuss and explore new innovations and technologies that may have the potential to address some of these challenges and gaps. And my last slide, please. I'd just like to acknowledge my colleagues at VITS-RHI, at the National Department of Health and the University of Brighton and Sussex Medical School, as well as our project prep team, our donors and our project beneficiaries. Thank you.
Thanks very much indeed, Saika. That was an excellent talk. We heard a lot about some of the challenges in the program, and I think in that last slide there, a really nice summary of some of the things that need to happen to address some of the gaps in the program. So before I introduce our next speaker, it's just a request for our audience. It's great to see such a healthy audience today. Please do submit questions to the speakers in the chat, and we can start to think about those questions and see who would like to field them for you. So yeah, please do that. Our next speaker is Francis Ndowa, a physician and director at the Skin and Human Medicine Clinic in Harare, Zimbabwe. Francis is an international consultant on surveillance, management and control of STIs, as well as on the containment of drug resistance towards these infections. Francis is the regional director of the Africa, Middle East and North Africa branch of the International Union Against STIs, a member of the WHO SRH HRP Scientific and Technical Advisory Group, as well as a member of the REACT Toolbox International Advisory Group on Antimicrobial Resistance. It's great to have you here today, Francis. Over to you.
Thank you. Greetings, everybody. So you have had the introduction. I will not dwell on that. That's my name there. I am going to sort of address some of the limitations and limited treatment options and management of treatment failures proposed at the global level, narrowing down some of the issues that have been highlighted by the talk by Ranmini and by Saika. So just to be on the same page in terms of where we had both speakers talk about syndromic case management, which most resource-constrained setting areas implement to manage STIs. The definition is the identification of a consistent group of symptoms and easily recognized signs that constitute a syndrome. And then the recommendation would be to treat for the main pathogens responsible for causing this syndrome, as was indicated by Ranmini in South Africa, for example. Gonorrhea and chlamydia are the commonest cause of urethritis, urethral discharge in men, and so those two infections must be treated, included in the syndromic approach. Or it can be that the infection is of public health concern. For example, even if there are low prevalences of syphilis in particular countries, syphilis is of public health concern. So in the treatment of genital ulcer disease, treatment for syphilis would be included for purposes of public health improvement. The syndromic diagnosis, however, we've heard, has got disadvantages, but it has advantages. The main advantages are that it provides immediate treatment and therefore decreased transmission and decreased complications. And one can also do surveillance using the syndromic approach so that everybody reports on genital ulcers seen, urethral discharge seen in men, instead of guessing that this is gonorrhea or that this is syphilis. Everybody will be reporting on the same syndrome. So it will sort of standardize the surveillance. So those advantages are there. Also, as Saika mentioned, there is need for training so that healthcare providers, particularly the primary healthcare level, can manage patients as they come at the primary healthcare setting, which is their first port of call, and they will be treated syndromically. So that increases coverage slightly of treating persons with STIs. But there are disadvantages. One needs to weigh the ability to treat as many infected people as possible against the risk of overtreatment, and that's been mentioned in that most women, for example, who present with vaginal discharge haven't actually got gonorrhea and chlamydia as the cause of the discharge. That is mostly caused by bacterial vaginosis and or Trichomonas vaginalis or both. But they would be treated for gonorrhea and chlamydia. So that's a disadvantage. There's also the issue of stigma that has been brought up, and one can label somebody as having an STI, especially in women with vaginal discharge, when in fact they haven't got an STI. And it has been postulated that syndromic management may play a role in the development of antimicrobial resistance. One would need to look at the data and information for that. This has been mentioned. I'm just repeating it because it's particularly important in that most of the infections, the STIs that we see, are asymptomatic. So, well, we don't see them. They're asymptomatic. The ones that we see, the symptomatic infections, are the tip of the iceberg. And this is mostly so in women, but also, as Saika mentioned, a lot of men also present with asymptomatic infection that will only be detected if we have a diagnostic tool. So this symptomatic infection can be addressed by the syndromic management, provided that patients recognize the problem and seek care. They need to come for care. If they don't come for care, they will not be treated. And also that healthcare providers are trained for that, and medicines should be available, as Saika mentioned. The asymptomatic infections are not addressed by the syndromic approach, and it wasn't intended for that. It was intended to manage syndromes. And if there is no symptom, there is no sign, there is no syndrome. And so here we need diagnostic tools, we need a screening strategy. We could have a diagnostic tool in place, but without a screening strategy that works, we would still not detect these infections. You could have a diagnostic tool and a screening strategy in place, but without the willingness of the population to be screened for STIs. Again, if that is the case, then you would not detect these asymptomatic infections. There would be need, once detected, for availability and accessibility of medicines to treat them. And there should always be capacity to monitor antimicrobial resistance so that appropriate antimicrobial agent is given in those situations. So if we look at where our syndromic management addresses our situation, it is right at the bottom of the cascade of infections. So people seeking care with symptomatic infections need to be given the correct diagnosis, correct treatment, so that we increase treatment completion and cure rates. But the cascade in real life is like this. The correct diagnosis is not made sometimes, correct treatment is not always available, and compliance tends to be poor, and the cure rate is even less for people who even seek care. So we would like to have this moved to the right to increase coverage of people that are cured. And that requires training, that requires facilities where you can examine the patient. It requires the availability of medicines. For the symptomatic patients in a population with STIs, not all of them avail themselves for this service. So we need to promote healthcare seeking behavior so that people are actually presenting at the healthcare facility, be it private or public, it doesn't matter. They should present for treatment of STIs. And some of the challenges are improving the attitudes of health personnel. Some people do not want to go to the clinics, the public sector clinics particularly, because of the attitudes of the health personnel, particularly so with adolescents. And we need to improve the quality of care and the availability of medicines. Some people will say, what's the point of going to that clinic? They don't have any medicines anyway. We need, as has been mentioned, to improve on our strategies for partner notification and how to reach the sex partners of people who present with STIs. We need case finding for people that come to the clinics and also a screening strategy. And if we have these two in place, we can improve the number of people, the proportion presenting, seeking care. And if we have appropriate training, then we can increase at least the reach to those people who present for care. But we do have a proportion that's asymptomatic. And as I've shown in the previous slide, this is probably the majority of people, particularly with chlamydia, where it has been referred to as the silent epidemic. So we need to have some strategies for improving detection of asymptomatic infections. At the population level, we need to put our prevention interventions, and these have been highlighted by the previous speakers. And as a public health approach, this is what we need to have in place to control STIs. But the syndromic management will only serve in situations where we have a symptom and a sign, such as, for example, genital ulcer disease. And it can be difficult to tell whether you're dealing with syphilis, chancroid, or herpes, even if you are experienced. And it has been shown, and I've only put two slides here, that in the setting of Africa, for example, the commonest cause now of genital ulcer disease is herpes simplex virus type 2. This has sort of changed. Before the 1990s, we used to see a lot of syphilis and a lot of chancroid, but herpes simplex has taken over. So in our management of the syndromes of genital ulcer disease, we need to take into account the fact that our biggest problem in there is herpes simplex virus infection. In the most recent study done in Zimbabwe in 2014-2015, using the MPCR amongst 200 patients, it was shown that 38% of the ulcers were due to herpes simplex. But surprisingly, for a country that thought that it had controlled its syphilis, 16% had Treponema pallidum detected. Chlamydia trachomatis LGV type was present in 1%, and there was no Haemophilus chickreyi detected in the 200 patients. And as is commonly encountered in many studies on genital ulcer disease, there is a certain proportion of ulcers where the pathogen causing the ulcers is not detected, and in this case it was almost 50%. You've already seen the data on urethral discharge in South Africa. I just repeat a little the data on the genital ulcer disease, similar situation that herpes simplex is the commonest cause of genital ulcers in the region. What was also interesting in the Zimbabwe study was that the syndromic approach would fail us if we relied on the syndrome itself. So here were patients presenting with genital ulcers, men presenting with genital ulcers and women presenting with genital ulcers who would have been treated for genital ulcer disease. But in about 23% of the men and 29% of the women, there was also gonorrhea and chlamydia detected. So you'll have people coming with genital ulcer disease without a urethral symptom such as urethritis, and they may not complain of vaginal discharge. So they will be treated for the genital ulcer disease according to the syndromic approach, but their gonorrhea and chlamydia will be missed unless we enter into a system where people presenting with any symptom or complaint of an STI are screened for other STIs in the process. We need a diagnostic test to do that. If we are looking at herpes simplex, which is now the commonest cause of genital ulcer disease globally, and we use the syndromic approach, we're going to be treating for syphilis for reasons that I mentioned, chancroid perhaps in the region because there's still anecdotal reports of chancroid, and we treat for herpes. But we need to sort of understand and convince the authorities, the policymakers, the financing establishments in our governments to buy into why are we going to treat HSV2 infection, which is an infection that's recurrent and incurable anyway. So we need to put arguments, control of HSV2 disease, perhaps, improve quality of life, certainly, and also impact on HIV transmission. But how do we do that? That's again a challenge that comes up. How do we implement an acyclovir, for example, the antiviral acyclovir strategy protocol in persons with recurrent infection? When do we start the treatment? When do we stop the treatment? Who do we treat for such a recurrent condition? So we need to have those elements, those strategies in place, those guidelines in place so that healthcare providers at the primary care level are aware of how to manage patients with genital ulcer disease, especially taking into account the herpes simplex virus. And we need access to that medication. In an assessment of 8 countries in sub-Saharan Africa, we looked at the availability of acyclovir at the primary healthcare clinic in those 8 countries. The interesting thing was all the 8 countries had acyclovir included in their guidelines on the management of genital ulcer disease. But not a single country had adequate supplies of acyclovir or valacyclovir at the primary healthcare clinic. If patients needed the acyclovir, they had to go and buy it themselves in the private sector. So there is a challenge where we will change our guidelines and include the management of HSV2 because it makes sense, because it is the commonest cause of genital ulcer disease, and yet not have acyclovir at the point of care for patients. That needs to be addressed. And for syphilis, well, it's easier to argue for syphilis. Why treat syphilis? It's a very important public health infection. And also, we've embarked on a global target of elimination of congenital syphilis. So we need to treat syphilis to reach that target. And it may impact on HIV transmission and acquisition. But we've had challenges. There's limited production of the most recommended, commonly used treatment for syphilis, benzathine penicillin, and countries have experienced shortages of benzathine penicillin. There is a fear of injecting penicillins by some healthcare providers because of the reactions that people may have with penicillin reactions, whether they are exaggerated or real. And the options are relatively limited, and they're not easy to take, and they're not as effective as penicillin. So we do have a challenge, and we will hear about new products later on in this session. And for urethral discharge, again, you cannot tell whether you're dealing with gonorrhea, chlamydia, or Mycoplasma genitalium. In a recent study in Zimbabwe confirming what was found in South Africa, the majority of people with urethral discharge. Men with urethral discharge had gonorrhea and chlamydia, but we saw a certain proportion with Mycoplasma genitalium and Trichomonas vaginalis. But for this, as has been mentioned, we have problems with treatment. We have a dwindling option available to us for treating these infections. We started a long time ago with penicillins. We can't use them anymore. Tetracyclines are out. Quinolones are out, as you heard from Ranmini's talk. Some countries are still using aminoglycosides in the same of gentamicin, which is effective. Zimbabwe has still got kanamycin in its guidelines, which is still effective. Macrolides, you've heard already that azithromycin is becoming a problem. Sputinomycin is in limited production, and so availability would be difficult, leaving us only with the third generation cephalosporins. And we've heard already that the oral Cafixine is a problem already. We are left with the injectable. So we need new products, new chemicals to treat these infections such as gonorrhea. This has been covered already in terms of limitations and strategies for that. So we do need to train people on monitoring and testing antimicrobial resistance. And WHO has embarked on that. And we do have the situation where we have, as has been mentioned by the two speakers, people that come with recurrent urethral discharge or recurrent infection. And one of the recommendations is that we must treat immediately, maybe with a higher dose of ceftriaxone. But if we don't succeed, we must treat the patients with laboratory-guided assistance. And that's a challenge, to have laboratory-guided assistance within the setting of poor resources. We need to strengthen the laboratories to do that. And that is not going to be achieved very easily. We do need to incorporate some diagnostic tests somewhere to enable us to at least screen and be definite about whether or not our treatment is appropriate. So we have a situation here where cephalosporins are the main class of antibiotic for treatment of gonococcal infections. There is a trend towards decreasing susceptibility to oral third-generation cephalosporins, and no new class of antibiotics are really available, but we'll hear a bit more about that later. So effective alternative treatments are limited. This is a big challenge. We will soon come across a situation where gonorrhea becomes untreatable unless we have a response to this. We need to train people, but can we do a laboratory-guided treatment approach in a setting where reagents are difficult to acquire for the culture of gonorrhea, and also the training of healthcare providers, laboratorians who have actually lost the skills of gonococcal culture because of the molecular testing? How feasible is that going to be, especially in Africa? It really is probably not a realistic option, but I'd like to be optimistic and say that we can do it. In terms of options, it's not an ethical option for men with visible urethral discharge who risk complications and may infect sex partners if we say we will not treat them with syndromically until we have results from a laboratory-guided treatment. So we have these challenges that we need to address. What we have here is the situation of where the syndromic approach is. We need here to improve the cascade using effective treatments, improving partner notification and data collection. We need to improve our diagnosis and case management. We need to encourage people to seek care. And when they seek care, we must provide them with effective services. We need to have a screening strategy in place, but even then, we need to make sure that people can avail themselves and they are willing to be screened. But most importantly, what we need to do is strengthen the primary prevention interventions, because that's where the problem is. If we don't turn off the tap, we will never control STIs. and we need to do that. And the challenges that we face in that are many, but we need to address them. There are individual issues of being screened or having a vaccine for prevention. There are cultural and social issues. There are vulnerabilities that are at stake at country level. We have a lack of screening strategies, and we have no affordable point of care tests. But even if we have screening strategies, they can be expensive and not taken up by the population and become not cost effective, and policymakers will be questioning that strategy in our faces. There is limited access to all these care services, and we have low diagnostic accuracy with the syndromic approach and affordable medicines, even though some of them are affordable now, like acyclovir, they're still not made available. And we have antimicrobial resistance to contend with, and healthcare and patient barriers to partner treatment are some of the challenges that we heard about already in South Africa, and how do we improve partner management. I would like to stop there.
Thanks very much, Francis, and thanks for focusing not just on challenges, but also solutions in that great talk. So very quickly now, we're just running a bit behind time. I just want to finally introduce our, our final speaker. Catherine Martin is a senior technical specialist at Wits RHI, South Africa. She's a medical doctor and epidemiologist with expertise in adolescent sexual and reproductive health, as well as HIV prevention and management. She's leading a research team looking at implementation sciences, implementation science approach in these areas. Catherine, over to you.
And thanks very much, Amir, and thank you for the opportunity to share some insights into client perspectives on STI services and how young people want to receive STI services. Next slide. So there are a number of platforms that are currently available for young people to access STI information and services. These include a national online platform that we have in South Africa, such as BeWise. We've got MyPrep and SheConquer's website and social media pages, which provide health information and also support linkage to services through service finder functionalities and engagement with clients through chatbots and Facebook Messenger. Youth zones, which are a model for a one-stop shop service provision, are provided at prioritized time slots for young people in primary care facilities. Guidelines support the provision of integrated services at primary care facilities with symptom screening and syndromic STI management. The guidelines also provide for a diagnostic approach, however, implementation is limited. But despite supportive guidelines, barriers to access and uptake of STI services remain, and the current approach may not be convenient or preferred by young people. Next slide. So what do young people really want when it comes to STI services? Wits RHI, in collaboration with Brighton Sussex University and funded by the NIHR, conducted the iPrep STI study, which aimed to establish preferences for the diagnosis and treatment of STIs and to assess the feasibility of integrating these preferences within the South African health system. Next slide. Formative research was conducted which informed the development of a discrete choice experiment survey. DCEs are a client-centered, theoretically robust method of estimating potential uptake given different service design characteristics. They enable a value or utility to be placed on different service characteristics, meaning the relative importance of each characteristic can be determined and an optimal combination designed from a user perspective. The DCE used for this study consisted of 4 attributes with 3 levels in each. These were developed into 12 choice sets for the survey. Participants were required to choose between different hypothetical STI testing and management options when attending health services. Next slide. There were 2 arms to the recruited through our project user WhatsApp groups, where a link to the survey was sent out through the groups and onwards by group members to invite participation in the study. Surveys were self-completed online without assistance from study staff. In the second arm, face-to-face recruitment was undertaken from SRH service waiting areas. This was conducted in an urban clinic in Tshwane in Gauteng province in South Africa, and in a second more rural area in Motherwell, the Eastern Cape province of South Africa. These surveys were completed with study staff assistance. Next slide. The discrete choice experiment consisted of 4 attributes with 3 levels in each. We looked at how the sample was taken, with either no sample, a self-sample, or a sample taken by a healthcare provider. For issuing of results, we looked at either the same day after 2 hours, the same day after 4 hours, or in 1 to 7 days online or via text. For treatment, either from a place nearby, such as a pharmacy, at a clinic during a follow-up, or at the clinic on the same day. And for partner notification, the options were either through a notification slip, notification by a healthcare provider, or the provision of expedited partner treatment. A conditional legit model was used to quantify the preference of the average individual, and latent class model to investigate subgroups within the data. Next slide. We conducted the surveys with 496 participants. The majority were females and just less than half were aged 15 to 24 years. Next slide. The population who participated in the study had risk factors for STIs. 20% reported STI symptoms at the time of the survey, 29% had ever been treated for an STI, 72% had had unprotected sex without a condom in the last year, 33% had had sex under the influence of alcohol or drugs, and 10% currently had more than one sexual partner. Next slide. The results here present the odds ratio of each level of attribute compared to the base level, with an odds ratio above 1 indicating a preference for the attribute level, and an odds ratio less than 1 indicating the attribute level is not preferred. There was a strong preference for self-sampling compared to healthcare provider sampling, with no preference if the sample was not taken and management provided according to symptoms. Participants were unwilling to wait for 4 hours for results, with receiving results via either a website or text message, or waiting 2 hours at the clinic being preferred. There was weak evidence indicating a preference for same-day treatment compared to a follow-up appointment, and some indication there may be a preference for receiving treatment at a local pharmacy, but these were not significant. There was a strong preference for expedited partner treatment, with participants not preferring the use of either a partner notification slip or partner notification by a healthcare provider. Next slide. There were 2 distinct groups of participants identified through latent class modeling. The majority showed a preference for self-care and out-of-facility management. They showed a strong preference for self-sampling with regards to sample collection. They were unwilling to wait for 4 hours for results and would prefer results to be issued on the same day or through an online platform. There was a strong preference for treatment to be issued at a local pharmacy or the same day at the clinic, but they did not want to return for a follow-up visit. And they also showed a strong preference for expedited partner therapy. These participants were more likely to be older than 25 years and from a rural location. The second group showed a preference for a healthcare provider facilitated management. They did not want to self-sample, but preferred sampling by a healthcare provider or syndromic management. They did not mind waiting at the clinic for 4 hours for results from a healthcare provider. They did not mind how treatment was provided, and they showed a strong preference for partner notification by a healthcare provider. These participants were more likely to be employed. Next slide. In conclusion, it is important to consider user perspectives when designing services in order to optimize service access and utilization. However, a one-size-fits-all approach is unlikely to work. We need to provide a choice of screening and treatment options which would suit different segments of clients. The majority of clients in our study showed a preference for a more self-led STI service, which should include the availability of self-screening for STIs and expansion of out-of-facility treatment points, which could improve treatment access and uptake. The implementation of expedited partner therapy, for which the majority of participants showed a strong preference, could also improve treatment uptake for partners and reduce the risk of reinfection. However, there are still those that show a preference for a healthcare provider-led or traditional service model, and we need to continue to strengthen these in order to optimize facility-based service provision. Last slide. I would just like to acknowledge the study participants, our colleagues at Wits RHI and the Department of Health, as well as the project funders, the NIHR Global Health Policy and Systems Research Program, as well as UNITAID. Thank you.
Thank you, Catherine, for a very great talk, and also the previous speakers for a very nice presentation. We will move on to the second part of this webinar, which is a question and answer as well as a panel discussion with a group of experts from the field. And for reasons of time, I would actually like to introduce the panel as a group. And if the panel members can switch on their videos, then we can get started. So our panel for today is Dr. Thato Chidarikire. She's the Director of HIV Prevention Programs in the National Department of Health of South Africa. We've got Dr. Cecilia Ferreyra, Infectious Diseases Specialist and Antimicrobial Resistance Officer at FIND. We've got Fernando, who's the Access Manager for GARDP. Professor Sam Phiri, Program Director at Partners of Hope in Malawi. And last, Professor Nicola Low from the University of Bern, Professor in Epidemiology and Public Health. So good day, everyone, and thank you for joining this panel discussion. We've heard from the previous speakers about a number of challenges and opportunities in the field of STIs, and to really start addressing the burden of infection and implementing the global health sector strategy. So what I would like to do, I can't see Thato. Is Thato online? Thato, are you there?
Yes, I am.
Okay. So what I would like to do is to start with Dr. Thato. One of the opportunities, I think, is to really strengthen program implementation. And maybe you could comment on what is needed to strengthen program implementation in your context in South Africa.
Thank you so much, and good afternoon, good morning, and good evening. So from the department perspective, we know that a challenge of STIs is a major challenge across the country. And in order to strengthen the program, we need to actually have a multi-sectoral approach, because we can't just leave it as a Department of Health challenge per se. So we need to call on everyone to ensure that we have this kind of support from researchers, NGOs, government, SANAC sectors, civil society, as well as scientists. And in order for that to happen, we actually need to work together to ensure that we actually strengthen our guidelines. We target in terms of implementation, and we make sure that we have granularized data that is informing policy guidance. So once we get this, then we'll be able to ensure that we get the implementation out there, because if we target, then we're able to get impact. And I feel that it is very important that we do, as well as ensuring issues of partner notification for STIs. Thank you.
Thank you, Thato. And I think one of the items that we hear a lot in the discussions globally is really the need to look for a point of care test. And I think it's often seen as the magic bullet, the thing that's going to solve all our problems. So I would actually like to hear from Cecilia, if she could comment on where we are with this point of care test and how you would position this in countries where there's little resources and where syndromic management actually works reasonably well.
Thank you, Remco, and thank you to the GARDP team for organizing this webinar. Yeah, I think that as we all heard in the course of the last 3 presentations, diagnosis is one of the key points against the battle of STIs, and the numbers are increasing. And I have to say that we have been working with most of the colleagues in this panel. We have been working since 2018 on developing a target product profile to define how the ideal test for gonorrhea should look like. And I think that a few years after, we are happy to say that we almost have a test that we are currently doing a study in South Africa with Remco and his colleagues to see the performance with fresh samples. The test is there. There's still a long way ahead, as you know, developing a product, then you need regulatory approvals and clinical trials to get those approvals. And in the case of this test in particular, it has been quite a challenge because there hasn't been any investment on lateral flow assays for gonorrhea for more than 25 years. So as some of our colleagues mentioned, in South Africa, testing will rely basically on molecular point of care, which, as we all know, they are not exactly point of care as they should, and the price remains almost unaffordable for most LMICs. So the idea of this lateral flow assay will be to position it in really decentralized health systems. It could be used at a rural levels. It could be used at a primary healthcare level. So it's basically a lateral flow assay with the format of the typical malaria or HIV test that just needs a reader, and the price should be less than $2. However, this looks really wonderful. But when we've been doing for the last year and a half discussions with 6 countries to better understand what are the practices and how this test could be easily introduced in those countries. And I have to say that the syndromic approach, although has been really useful to fight against STIs, it will be really hard to turn Ministry of Health to move to a theological approach, because still the course of a treatment, even combination of ceftriaxone and azithromycin, is cheaper than $1. So most of these countries were asking, why should I be investing $3 for a test when the treatment is cheaper? And I think there is a lot of work being done by Nicola, by Theo, on showing what is the price of resistance. The price of gonorrhea resistance is not only about how much a new drug will cost, but it's a potential cost also on how many times this patient will be coming back to the clinic, cultures, sequencing, and another molecular testing that at the end makes the price even harder. And just to finish, I think it's a hard way for testing, especially in the context of STIs, where, as Francis mentioned, you have a huge proportion of asymptomatic patients that you are not seeing. So those are not having access to treatment. But then you have those who are symptomatic patients who most of the times are being overtreated. And I think there is still a long way to go to find what will be the right operational model to find the balance between catching those patients who needed treatment and providing the right treatment for those who need it. And I will stop here. Give the floor. Thank you very much, Remco.
Thanks, Cecilia. And I think you raise a valid point about the cost of treatment and the cost of diagnostic testing. I think that's a major issue in our context as well. And I think we've heard from several of the previous speakers about the therapeutic options, and that resistance in gonorrhea is rising. We're slowly running out of options, and as you all know, the cephalosporins, in particular ceftriaxone, has really become our mainstay, and in cases our only option for treatment. So I would like to know from Fernando, one of the disadvantages, I think, of ceftriaxone is that it is an injection, which provides some of the implementation barriers, as well as that it's our only option at the moment. So Could you perhaps comment on any new therapeutic options in the pipeline, especially oral options?
Thank you very much, Remco. So I will say it very shortly because I think we are running out of time. Well, in GARDP, our focus is really to develop new antibiotics, but also to make them accessible and to ensure that they are appropriately used. And in this regard, in the field of STIs, we are partnering with a company called Entasis to develop Soliflodacin, which is a first treatment developed for gonorrhea specifically, and it's an oral treatment that once development is finished will be indicated for the treatment of uncomplicated anorectal and urogenital gonorrhea. So we have a license with Entasis to market the product in 168 countries, and that includes all African countries. And we have done, we have successfully achieved phase 2, and we are in the middle of the phase 3. There are sites in South Africa, like many of you know. But I just want to finish very quickly because that we think that can be a very good opportunity. Soliflodacin, as you say, being an oral treatment for some of the challenges we heard about, for instance, problems with treatment uptake that were mentioned by Saika, or maybe addressing partner treatment, having an oral treatment is an advantage. But also in the future, we know Soliflodacin because we have studied it has activity against also resistant strains of gonorrhea in vitro. So that opens opportunities to use it, as I say, maybe in partners in specific populations, combining it with a new point of care, trying to increase the uptake of treatment, but also maybe looking at patients who fail, which is also a challenge identified today. But that would require additional research, and we are ready to move into that. We need to understand better how the drug will be suitable for these uses, how it will, in terms of developing resistance, how it will manage. So we're now in the middle of the phase 3, and we are very optimistic and for working with all of you to really see if this new tool can address some of those challenges. And I won't say more because really we're running out of time. So everyone has an opportunity to say something.
Thanks, Fernando, and I agree. I mean, Soliflodacin is quite interesting also in the context of partner management. And I think in general, partner management is a big gap or a big challenge in our STI programs and in control, in particular in the case of asymptomatic partners. So maybe I would like to ask Sam, what are your thoughts around how could we improve partner notification, and what magic interventions could we think of to really strengthen that component of our programs?
So thanks, Remco. Great actually panel from the previous speakers and also the presentations which have been done. So I think, as we know very well, I'm really glad that this webinar was organized to make sure that we repeat some of the discussions at ICASA. And the STIs, we know that the program of sexually transmitted infections in many countries, including Malawi, I think over time, previously it was really strong as it was, but later on it was overtaken up by other programs, and sometimes not much attention was put to that. But currently this has come up and it is now on the radar, and for partner notification, which is a key component of case management for STIs. What I think I would mention is that because currently most countries have been using, including Malawi, the passive partner notification, whereby an index case would be given a slip and then distributed to the sexual partners, and then allow them to go to any of the clinics. So you can only report how much partner slips were given, but really to look at how many of those would return, it has been an issue. So I think one of the things I thought we could do is we could utilize the active components which are currently available, for example, within the HIV programming, there's actually the HIV index case testing, which is happening to make sure that once the new positives are found, then you make actually a provision whether you the index case would bring the partner, or the partner would go somewhere else, or you would want the facility staff to be involved in the tracing of the partners. So I think we could use the index case testing strategy that we are using in the HIV, and also this can be actually used in the STIs, whereby an option of active partner tracing can be done for syndromic management of STIs. I know that this is intensive in terms of the cadre of staff that will be able to do this. At the same time, I know that transportation and the movement of the staff to move to different places can be an issue. But I think the programs can invest and use this strategy to make sure that we are able to curb because if we don't treat the partners, we will not break the cycle of the STI. In that case, that can also lead to even the increase of the HIV incidence. And currently, for example, countries like Malawi have reached the epidemic control, would want to make sure that as we are looking at the last mile of finding the last positives, we should also make sure that other strategies, including STI management and control, should be optimized. So I think that's what I could do, comment for now. Over to you, Remco.
Thanks, Sam. Very much appreciated. And then our last panelist, Nicola. One of the things I always learn is modeling provides us with the answer, especially if there's paucity of data. So what opportunities do you see for modeling to help us guide on some of these implementation questions and antimicrobial resistance developments?
Thank you for that question, Remco. The first thing that I will say is that with a paucity of data, it's actually very, very difficult to do modeling that gives the answers that people want. And of course, it's very easy for me to sit here in an office and say we need more and better data, because in general, I'm not the one who has to go into the field and go and collect the data. But what I would like to say is that modeling has enormous potential for addressing and to help people make decisions about what are important areas and what are important interventions and what effects they might have. What I would like to, and the data that you collect depend on your modeling question, and the model depends on the question that you want to answer. But I think that one area of data collection that we often neglect in STIs is about the clinical outcomes of these infections. So bacterial STIs that result in pelvic inflammatory disease, in ectopic pregnancies and infertility, those are data that we really, really are lacking worldwide, but particularly in low and middle income countries, so that we can work out the proportion of these consequences that are the result of STIs, because that's what we really, really want to prevent. We want to prevent reproductive tract morbidity. We want to prevent epididymoitis in men. We want to prevent HIV as a consequence when STIs are cofactors. And so those are links that I think that we really want to make, and that if I have the opportunity to encourage people to collect data, then that was my resolution for 2022. Thank you.
Thanks, Nicola, and thanks to the panel members. Amir, can I hand back to you for some final questions and to wrap up, please?
Yeah, thanks very much, Remco, and to the panel. We have been running a bit short on time, so we haven't had a lot of time for questions from the audience, but one question, and this is to all of you in the panel, if anyone would be interested to take it. One question that came in from the audience was asking about how important is it to have an oral option for the treatment of gonorrhea, and we've heard that some of the new therapies that we hope will become available will be oral. Would anyone like to respond briefly to that question from the audience? Sam or Nicola or Saika, do you feel an oral treatment gives extra value, or is it not so important in this context? What's your feeling?
Maybe if I could just mention, I think what we're hearing, and we're still providing prevention services also within the context of COVID. And so we've been thinking particularly around, how do we decentralize, demedicalize HIV prevention services? So having an oral treatment where potentially you don't require someone to come back to a health facility that might be able to be delivered in a more decentralized way or picked up at non-facility points could be really useful in terms of access. And we also hear, anecdotally, that young people don't like injections. We hear men don't like injections. So, it would be helpful to look at whether or not we kind of improve access and acceptability and feasibility of these services. And obviously, having an oral treatment would be is much easier for partner treatment, because you don't necessarily require the partner to come back in. So I think there might be several advantages, and if that oral treatment was also short in duration or even a stat dose, that would be kind of first prize.
Just to add to that, actually, thanks, Saika, for that. I would also watch that if an oral for gonorrhea would come, it would be, I think, a most welcome idea. Malawi has maintained the gentamicin, and our IMICs have remained really acceptable. However, I think knowing that the opportunity costs beyond the delivery of the gentamicin itself would be, although it is cheap, but at least if there's something else that can be swallowed, as Saika is saying, and a start dose would really be great, that can be used in that case, and then it can be able to be given to other to partners without probably coming to the facility. So I think that's that. Although I know that some groups actually prefer, and they believe that when you get an injection, you've got the right medication for that condition. But otherwise, I think I would support the oral to come in this case. Over to you, Amir.
Great. No, well, thank you very much, Sam, Saika, and indeed thanks to all the panel for your time, for excellent presentations and discussion. I think it would be great to continue this discussion, but sadly we are out of time. But I mean, I think if people have comments and follow-up thoughts, they can submit them to GARDP. So just to very quickly wrap up. We've heard about a lot of challenges in the STI field, but we've heard about some really important new things that are coming, both in terms of diagnostics and therapeutics. And I think what we've got a sense of from you all is that is potentially going to change not just our ability to manage STIs the way we're doing, but potentially to change the way we're managing STIs and to change our strategies and our approach for the better. So thank you all for giving us that snapshot. Thanks to our audience and to the Revive platform for letting us put this together. And hopefully this is a conversation we can continue in some way or another. So thank you, everyone.
Thank you, Amir and Remco, for moderating today's Q&A. And of course, thank you very much to all the speakers and panelists for participating in today's session. Our next webinars will be announced very soon. However, the Antimicrobial Chemotherapy Conference will be taking place on the 2nd and 3rd of February 2022. Registration for this conference is free of charge, and available for all around the world. So please do register, which you can do easily at the link accconference.com. Thanks everyone for joining today. Please do join us again in future and spread the word and encourage your colleagues to join as well. Thanks again and goodbye.